Thank you, Chairperson, and thanks the scientific committee and ISOT to give the opportunity. So, after hearing the challenges, the immunosuppression, again, earlier he said that there is no different immunosuppression which is required. It's not moving. Okay. So, even the transplant is evolved from 1954 to 68, and then azathioprine, all other things which have evolved. Even the ABO incompatible evolved from 1915, where the Humes did the first transplant which failed, and 1984 the Slapak and introduced the concept of plasmapheresis, and Alexander carried it, and the Japanese took over in 1989. After that, we have significant improvement in the graft function and the survival rates. So, with the introduction of azathioprine, then cyclosporin, TAC-MMF, and even the others, Bella, which is coming in, the rejection rates are significantly reduced, and the improvement in the graft function was significantly there. So, for the August audience, I need not have to go into the details. So, we have multiple combinations of drugs which are available. We use triple immunosuppression to attack the signal 1, signal 2, and signal 3. Now we have steroids, we use calcineurins to attack the IL-3 and the calcineurin pathway, and we use we use azathioprine or an MMF or an mTOR to further reduce the proliferation. And in addition to that, we use induction therapy with either an ATG or even IL-2. Even the co-stimulatory package, belatacept, has also significantly improved the survival, but as of today, it is not available. So the induction, it starts with the rituximab. We use 200 milligram now instead of 500 milligram day minus 14 days, and then we wait for 4 days to act, and then we lose the plasmapheresis. How many sessions are required? We start day minus 14 only, and we use 0.1 milligram per kg tacrolimus and 750 BD or 500 BD depending on the patient, MMF, and 7 days we start prednisolone. On the induction, we decide if there is any HLA incompatibility along with ABO, use ATG. In the first 10 transplants, we used ATG, but there was more infections. So we now use IL-2 or sometimes no induction therapy in almost or 40% of patients when there is no single bead is negative, and we did a plasmapheresis with rituximab, and the CD19 is less than 1%. So we don't do use post-transplant, and we know that first 3 days of the silent phase, when we reduce the antibody, there is a regeneration of the antibody which happens. That is the reason the critical period is 3 to 14 days is the critical period, and after that it is a stable, it's almost equal to the ABO compatible transplants. What about the immunosuppression maintenance and our ABO incompatible transplant working group recommendation, which was published in 2019, says no immunosuppression change as compared to the compatible transplant, because after the 3 weeks it is same, and even the British guidelines also recommend the same. The most important thing what we use is steroid. So steroid is ways, and people use steroid avoidance protocol also because the infections are higher. So, and usually what we use is methylprednisolone milligram per kg, taper it to 10 milligram by 2 and continue with 5 milligram. This was the Trinix study. We used elimination and slow dose continuation. They shown that it is significantly almost similar in those patients who are chosen similarly. So they had when the viremia by CMV, BKV were also much less, and DGF was also much less. PTDM was significantly lower, almost 3% as compared to this thing. So it was significant reduction, and the pyelonephritis sepsis were lower. So elimination is possible, but again, earlier papers have shown this is all ABO compatible, and there is no study in ABO incompatible which was published to show the removal of or elimination of steroid better. Calcineurins, you all know, it improved the survival of short term and the graft survival 1 to 4 hours significantly, but again, we are failing to improve the long term possibly, and the earlier studies of 70s have shown without calcineurin also they did well. Which one is better, TAC versus cyclosporin? TAC is always superior as compared to the immunosuppression. The outcome of the percentage of graft survival was significantly higher as compared to cyclosporin. But again, in some situations where the TAC intolerance or a TMA happens, we change over to cyclosporin to see, because one always, if had TMA with one, it may not happen with the other. The DSA formation, if you see, which is one of the most important thing on the long run, and the cyclosporin as compared to tacrolimus, the cyclosporin patient had more de novo DSA. Even in these are the two Huang study and the LENMI, which have shown they had a high DSA formation. So less rejections and the less DSA, so the TAC is better. And how much dose of TAC? And again, the Allied Symphony study, it showed compared the sirolimus, low-dose tacrolimus, high low-dose calcineurin, cyclosporin, and standard dose have shown that the tacrolimus low-dose with MMF is much better. They had recommended a 3 to 7 nanograms as this, but most of the clinicians, they kept it 6 to 7, not less than that. And the survival was significantly higher in the short-term outcome. So this was the study which was shown that the DSA formation is higher when you have less tacrolimus lows in the first year. This was 884 patients. They have shown that the DSA was negative in 425 and 118 it was there. And if you see that those who have DSA was free was in those patients who had TAC level was more than 8 and even 6.5 to 9. So those patients who have more 6.5 or 6.7, the DSA formation is significantly less as compared to 4.5 to 5.9 or less than that, they had more DSA. Then coming to the mycophenolate, earlier the USRDS data have shown slightly better with mycophenolate, the death censored graft survival, but again, no data significantly, but earlier rejections were slightly less. And so this was one of the study which tacrolimus dose was used, whether to use high dose or low dose, that is 0.75, 0.1 versus links. If you use 0.1 also, it is reasonably better, and you need not have to have a higher changes. Here also they used 750 milligram of MMF, and they've shown the outcomes are significantly better. So this is MMF, which is showing slightly higher rejections as compared to azathioprine, but the overall survival was not significantly different. So initially has an edge, but again, overall outcome is the same. This is the overall decade effect, what we can say, from 2019-89 to 2019, where the cyclosporin, azathioprine, desferrin, they were used, and then 2004 to 2004, and we used tacrolimus MMF. The survival was significantly changed. This is from Japan experience. So there was significant change. The group 1 survival, if you see that now we have around 85 and 87% survival. So over the decade, we have evolved with immunosuppression and the TAC MMF, and the rejections, if you see, the earlier people will have 48%, now it is only a 15% rejections, overall rejections. So MMF TAC combination regimen provides an excellent graft survival initially. So the dose what you start with is 1.5 milligram and 2, which is better. If you use 2 milligram, you have more less acute rejections, but not significant. But leukopenia is significantly higher. BKV is significantly higher, and overall, otherwise there is no. So in order to reduce the infections, I think 1.5 milligram, 750 milligram is reasonable. You may have to reduce it looking at the other infections and the leukopenia. To conclude, MMF and azathioprine, little bit early rejections are higher, antimetabolites complications are there, you can choose it. So it's slight edge over azathioprine, but cost is more. It is an incompatible patients, we are more facing infections and the ABMR. So infection was significantly higher, almost around 3 times significantly or 4 times higher, and the ABMR is also higher. This was from the US group. And so antimetabolites like mTOR, it can also reduce the rejections if it is in proper dose, along with tacrolimus or tacrolimus minimization, and it protects even the fibrosis and the remodeling. So it can be used in transform pretty it has significantly showed reduction in the tacrolimus dose as compared to when you're using MMF, you can reduce, and the overall short-term results were reasonably good. So you can reduce the long-term complication of tacrolimus toxicity and using everolimus. Here, they have shown significant reduction in the CMV and BKV and the overall side effects of the viruses. And so it basically mTOR, its CMV, it significantly increases CMV specific CD8 cells, blocks the phosphatidylate 3 kinase pathway for crucial, even similarly suppresses the viral replication on the protein kinase activated by the B cell, and the mTOR, it increases the uh, CD8 T cells for specific to virus. So see, viral infections are less. Even the parvo also people have used with everolimus and they have get away with it. The belatacept is the core stimulatory molecule which we have used in the trial. It also shows that less intensive and more intensive regimen, it blocks the co-stimulatory blockade, and it significantly increases the GFR, and the graft losses are almost similar. So this is the trial of conversion, and this thing significantly showed that it is stable or increased GFR as compared to the calcineurin in the benefit or benefit extension. So the significant maintenance of the GFR, it is on a long run reduces the complications of cardiovascular risk. The thrombotic microangiopathy is everybody is afraid with ABO incompatible transplant. Either it's a histologically, people have started using eculizumab to improve the outcome. So dependent predictors of outcome, you will see sometimes the TMA, and it may be along with the ABMR. So when you have TMA, the outcome is significantly poorer. Eculizumab has been used associated with the antibody mediated rejection in ABO incompatible. Sometimes you don't see microinflammation, but if you use it early in the course of the disease. So this is the post-op one, he had things, and eculizumab started on day 6, and there was a significant improvement which happens in the renal function, and even the agglutinin titer completely reduces. So the antibody reduces, and the stabilization of the hemoglobin and the platelet improves, and the renal function, creatinine also, it significantly by 2 or 3 months, it significantly stabilizes. So eculizumab therapy is beneficial. This is the successful adjuvant therapy in desensitization protocol. Some of the patients who are high risk, either genetically or even the high titers or rebound titers are higher. These are the patients. There are 2 cases which they have shown that eculizumab, it can reduce the ABMR or the TMA. There was a paper, belatacept also, it's a co-stimulatory blockage. Eculizumab is costlier, and the belatacept also, it was costly, but it was not available. This is the patient where they had a TMA, and the people used sirolimus to because they had to stop because they thought that it is a tacrolimus induced TMA, and they stopped and used sirolimus. Then he developed lymphocyl, and there's a compression and the drainage, and he had a collection. So because of the sirolimus increases lymphocyl, and this person was given belatacept, and he did well. We have also had a patient who had a TMA, and we were able to procure belatacept. He did well, and after 2 years, we changed it to an everolimus, and he is on everolimus now. Another latest was enzyme converted kidneys of ABI incompatible. Basically, what we are seeing was that recipient centric. We are doing a protocol to reduce the antibody reduction and of the titer, and the donor centric is converting the A kidneys while they are in the hypothermic perfusion to remove the A antigen. It showed that 2 days it was good in the model, and then it started after 3 days the antigen reappeared. It's possibly the regeneration of the antigen which happens. That is the reason the critical period is 3 to 7 days or 3 to 14 days is a critical period for our in renal transplant patients. Also, the study has shown, but it possibly by changing the endothelial antigen, we will be able to transplant more patients. So just to nutshell, we have to have a reactive approach or a proactive approach so that high risk patients, the desensitization, CNI, we should increase or maintain a good immunosuppression as compared to low risk. You can monitor only, and the FK you can do it. And so targeting in high risk patients or not reducing the immunosuppression and balancing with the infections is the way to go, so that we can maintain low graft losses with the immunological injury, even the recurrence and the nephrotoxicity of the drugs, and the death functioning graft can be reduced with mTOR on neoplasia can be reduced, and the transform study which has shown. This is the multicentric study which Dr. Vijay Kher already alluded. There's a reasonably good survival which achieved when you do all these things. And this is the 25 years those people have achieved, and 112 patients which showed that the mean age was lower, Caucasian, live donor transplant, and the HLA zero mismatch was 25% of patients. And these are all the acute rejection in 21 patients. Still, they were achieved 25 years. Malignancy and the infection was so significant. So we can achieve 25 years. We need to have a proper follow-up. So ABO incompatible combination immunosuppression reduces the rejection episodes. Induction therapy desensitization to reduce the early rejections. Medication adherence is most important. Late rejections are because of the inadherence, and the balance between the rejection and infection is important. CMI minimization with everolimus may reduce the BK. Belatacept may have a role, and so ABO incompatibility is going to increase by 25 to 30% of transplants, which you can't otherwise. You will have to go for swab transplant. Thank you very much.